Well, welcome to the second webinar series organized by Progenesis Academy. Today, we're going to be talking to the world experts in IVF practice. Welcome, Dr. Beltsos. Dr. Beltsos is the director for Vios Fertility Institute. And we have with us Dr. Paulson. Dr. Paulson is the director for USC Fertility. And we have Jason, Dr. Swain, Jason Swain, who is the corporate director for CCRM. And today we're going to be talking about IVF and how COVID-19 fits into that equation. There are lots of challenges that we're going to be discussing today. I'm going to start my questions. So the way the webinar will be organized is that we're going to ask some questions for our physicians and we're going to get some answers. And then the first part will be the clinical aspects. Then we're going to transition into the laboratory aspects, which is the IVF lab, the culturing system, the cryopreservation, etc. And towards the end of this session, we're going to have some questions for the audience. We're going to collect some of those answers, and then we're going to announce what the feedback was from the audience. So let's start first with the first question, which is, are you currently seeing any patients? That's for Dr. Paulson.
Well, we're seeing some, not very many. Our normal volume is about 500 cycles a year, so that's about 10 retrievals a week, and we're maybe doing about 1 or 2 these days. We decided we could not stop doing fertility preservation for our cancer patients, and we have other patients who are in severe, let's say, diminished ovarian reserve. They're sort of teetering on the verge of ovarian insufficiency, and so a couple of those have gone through as well. But all of our regular patients, so no embryo transfers, and all of our regular patients have been at least delayed by a month, sort of in accordance with the ASRM suggestion. So virtually none. We're at about 5 to 10% of our normal volume, but our doors are open so we're all here.
Fantastic.
Yeah, we too are seeing patients, and when we talk about seeing patients, we have our telemedicine. But in specific to IVF, we have sort of done the very similar to what you are doing, and that is we are doing procedures. I did a egg retrieval today on one of our Hodgkin's lymphoma patients. Mm-hmm. And we are doing patients that wanted or needed more urgent care, and specifically some have some medical issues. We had some patients that are coming off of Depo-Lupron that were prepping for procedures, and so we have been doing some retrievals. We've stopped starting patients, but we expect that we will start patients again soon. And I think that the diagnostic testing is a question, like doing some blood work, some ultrasounds. We are doing some of that, trying to minimize how many times patients come into the office, but also allowing them a chance to get a sense of where their body's at and or prepare for IVF when they're allowed to proceed.
Fantastic. Well, obviously, a lot of patients may have a little bit of frustration because they don't have the same access. How do you manage that expectation?
Well, I mean, I think a lot of patients are already concerned of their own volition. I mean, they're all concerned. Is it okay? Are you open? That's usually the first question. Yeah. And if so, then can I come in, and under what circumstances? And I think one of the benefits of sort of this time out that we've had for the last month or so has been that I think we've been able to, we've adapted a little bit. We've learned how to do, like Angie says, the telemedicine. We're doing all of our consults via Zoom. That's very helpful. That'll help us I think that's great. I think we're gonna do that again in the future, even after it's not really necessary. And sort
Yeah.
of realizing that we don't have to have the partners coming in and stuff like that. I think it's been helpful for that and managing their expectations. The most difficult ones, of course, are the patients who are with the panic in their eyes, and they know that they feel like today is their last chance, not tomorrow, today is their last chance. And those, to convince them that 2 weeks is probably not going to make a big difference is difficult. So I don't know that I have any particular wisdom except to say, we think this will be okay, and we're right here, and we'll be here for you when the time comes.
I think those are really excellent points. And for managing someone who's already very anxious about their ability to have a family, I think some important take homes that we've thought about really is being available for these conversations and being able to have telemedicine, whether you use telemedicine like we're talking today on this webinar type of video conferencing, or whether it be by phone, that can really help a lot to talk about where they're at and what their options are. And another thing that I think is always helpful to kind of calm the situation is to have a plan written in pencil. So we're going to expect that you're going to get your period on this day. We might wait a month, but then the next cycle, and some soft dates about when things might start to happen for a retrieval and transfer can really help people wrap their arms around this ambiguity of, we have no idea what and when things will start to be available in regards to services. Another thing that we found is really talking about some coping mechanisms and things to do while you're waiting, foods to eat, micronutrient supplements, things like that, and things not to do. And we have talked about managing stress, how much coffee people are drinking while they're sitting at home and doing their work from their couch. And another interesting thing we did is we're doing some online webinars like this with our patients directly about different topics, and being able to pull in some experts. We did some with patients who were, for example, in third party using surrogates and what that's like. We've had a pediatrician come on and talk about what a newborn can do. So I think that managing patient expectations and healthy living, getting rest, eating well, I think all those can be very impactful while people are in pause.
Fantastic. And for those patients that you are currently seeing, how do you manage or you control for the environments, the exposure? What procedure you have in place to minimize that there is some sort of exposure between the patients and the staff and etc.?
Do you want to go first, Angie?
I'll start with preventative measures, some things that obviously utilizing telemedicine and making the doctor's appointments virtual, whether it be phone or video, is critical. I think another thing we've implemented is that a lot of patients that are at the front desk and with a patient coordinator wanting to make their next appointment, or they might have questions about insurance or payments, doing all that by phone is very important. So we discourage people from spending too much time with the front desk and people that are working there. All of our patients are required to wear masks or a facial covering, whether that be a scarf or a mask, and some have arrived without one. And if we don't have something on site for them, then we will ask them to reschedule. All the staff is also asked to wear masks. We keep 6 feet distancing so that when patients come into the waiting room, there's only 1 or 2 patients allowed in the waiting area, depending on which office it is. And the rest of the patients are asked to wait in their cars. And once their appointment time comes in for blood or ultrasound, then they are texted to come in. So really mitigating the chance that there would be close contact with staff and or other patients. Of course, washing hands. As soon as they arrive, they get their temperature taken, symptoms checked, and asked to wash their hands immediately, along with our staff, and keeping the area particularly clean. So we also, as you had mentioned, really don't want to have extra people in the office. So if there's a partner, a spouse, a child, we ask that people not come in with anyone else. And some patients come in with translators. We keep the translators on the phone. And the other important thing is just trying to manage how many times you bring them in. So normally we might have someone come in more frequently, whether it be pregnancy monitoring or some of these monitorings to prepare, trying to keep them in the office for as short of a time as possible and as infrequent as possible.
Fantastic.
Yeah, so all of that, and I agree with all of that. And in fact, what you're doing is sort of some of the procedures that we're considering as we start thinking about ramping up. So we have a doorbell outside in the hallway, and they have to ring the doorbell, and then somebody goes out and they take their temperature outside, and they have to answer those questions. No, I've not had a fever. I've not traveled to Wuhan, and I've not been anywhere, anywhere near anyone with a known disease. And then they're brought in, and like you say, they have to have face covering. We talk about that. No partner. Wash your hands. We put them into the room. Room is cleaned between patients and so forth. And I think everything you said, I agree with. We've actually cut back on our staff because it's hard to keep 6-foot distance if we have all the nurses here. So the nurses are kind of staggering their shifts a little bit. We're thinking that as we start to ramp up, we may have to actually increase the amount of time that we are available for ultrasound, because we probably don't want to have appointments any more frequently than every 15 minutes, something like that. We're going to see how that goes.
Yeah, that's a good point.
To try to minimize that. One thing I will share with you is as somebody who really dislikes Purell, I was able to get the laboratory director to get some laboratory ethanol, which I have in a spray bottle, and that's so much more pleasant on my hands. And you can splash that on and wipe it off. 96% ethanol does not burn, doesn't do anything, and doesn't have that sticky feeling that you get from the Purell. So I think that's about the only piece of wisdom I have there. But the same thing, wear masks. We all wear masks. The patients all wear masks. Minimize the number of visits to the office. I think that's key. You're absolutely right. We see them way too often. And I like it because I think it sort of keeps us in close contact. We get an opportunity to keep asking them, are you sure you did this? Everything's going right. But I think you can cut back on it and just do all of that via telephone.
Very good. Well, very recently, on April 7, we have seen an adjustment of the New York State, their position on reproductive medicine, taking it as essential. What's going on? What's your first, 2 questions. First is, what is your assessment or, take on that? And second, tell us a little bit about your local authority, what their position on reproductive medicine at this time.
So Chicago, Angie?
We have, I think, as far as Governor Cuomo, he describes this reproductive health and health care as essential, as does our governor in Illinois. Governor Pritzker, his executive order that was issued on March 20th says essential businesses and operations, and reproductive healthcare providers are part of that, quote unquote, essential services. We do have offices in other states like Missouri as well as Wisconsin. Wisconsin says obstetrics and gynecology. And, again, we were looking at like when the peak comes, and I think, Nabil, you bring up a really important question, is that this is governed by the state. It's governed by the governor's executive orders, and their scientists, their demographics and the geography is very relevant to answering some of these questions because, for example, our peak resource use in Illinois was April 8th, But for our St. Louis, Missouri group, it's not until April 28th. And so I think you do have to kind of navigate what's happening in your community. And so for us, again, our governor specified specifically, as did Como, that reproductive health care is essential.
Well, analogous situation in California, Governor Newsom also has declared it. I presume that they were talking more about, contraceptive care and abortion services, but it's fine. I think we all know that infertility is a disease and are very passionate about providing this care to our patients. And so beyond taking a quick time out to try to figure out what's happening, I think we're all kind of anxious to get back to work and to rely on that order. But I think what Angie says is really important, and that is that the local prevailing situation is going to be very important, because I think if I were in the middle of New York or in the middle of Brooklyn, let's say, where my daughter practices, that would be very different from being here in California. And in Los Angeles, we get to work by getting into a car and driving on a freeway. That's very different from getting into a subway and transporting ourselves back and forth. So I think there will be local and regional differences that will be not just the way the local government interprets it and the local public health department declares it, but also just the reality of what's happening and how many cases there are and how quickly people started socially isolating and so forth. So I think it'll be interesting as time goes along, but I think suffice it to say that we're all anxious to get back to work, and the question is how quickly, and how that may vary from California to Chicago, let's say, and to Wisconsin, as you say, and to New York, of course.
Absolutely. I think it's going to depend on each state and the peak in each state and the special circumstance in that state. But this is like Dr. Beltsos was saying earlier, it's not just a matter of 2 weeks. It'll take many months, right? And so how do you see your practice operating? Do you foresee some adjustments as you go, or how do you see that operation? Because this could be a 6-month or 8-month period of time. Obviously, it's going to be really intense at the beginning. It's going to slow down as the pandemic decreases over time.
Well, to me, that was so disappointing when I realized that a magic bullet is not coming. I will admit that I continued to think, oh, it's not a problem. We'll have an immune test. We'll have a test very quickly. The capitalist system will save us because someone wants to make $1 billion by coming up with a test, and they're going to do it very quickly. And it has not happened. And I hope that it happens. But I think we have to presume that we're going to go back to work without reliable, quick, reproducible. We can't test everyone that walks through the door every day that they walk in.
Yeah.
Right.
Right? Never mind that it's uncomfortable and so on. So that's not going to happen. So we have to adjust to that. And yes, Nabil, you're right. This may go on for months or years. What if we don't really have a good vaccine for 18 months? 18 months, that's a long time. And during that time, we can't just tell these patients to wait at home. That's not a reality. So I think all the things that Angie and I talked about at the beginning, trying to mitigate the risk and trying to provide the care that, we trained to provide and we are passionate about making available to our patients.
Yeah, I think so, because there is continued ambiguity, and I think we won't have the clarity that we were hoping for in 2 weeks. And I tell people it could be 2 weeks, 2 months, or 2 years before we have any sense of normalcy. And with that, you have to manage each individual case. So as a patient or as a provider, I do think you have to sit down and go over each person's story and look forward and when I mean look forward, the past, as we talked about last night, is we are here today. This is our new reality, and it's not going to change dramatically in a couple of weeks or a couple of months. So now we have to go forward with what we know today and anticipating some hopefully help and clarity in the months to come.
Yeah. So for now, when you have a patient, it comes to the clinic, the first thing you do is you check their temperature, you kind of screen them before. Now with the genetic testing, maybe you will have option to look for antibodies and look for RNA. Do you see that happening where you can't get a patient till they get screened first and get the results? And do you see that as a practical solution or part of the solution?
Well, you're talking about a 48-hour turnaround. Yes, I think the testing belongs in there and is going to be a component. I think we still don't have adequate clarity on what the false positive, false negative rate is. And furthermore, presence or absence of antibodies, you know, how reassuring is it? So yes, I think testing is going to be a big part of it. I thought it was going to be the linchpin, and now it looks like it's not. At least not in the near future. Maybe in farther along, maybe a year from now, then that'll be routine. Maybe then yes, you'll have a dipstick or something like that. But at this point in time, I'm not seeing it as being an essential component of the treatment because you just can't do it often enough. You don't know if the person. It's quite possible the person can be negative and already be infected and be in the pre-symptomatic phase. So you cannot assume that someone who has a negative test is not going to infect you, and you cannot assume that if they have a positive antibody test, for that matter, that they are no longer infectious and that they are not going to transmit it to someone else. So I think we're going to have to use, universal precautions and all of them.
Yeah, I think, Nabil, this is one of the most provocative questions of the evening, and that is, how do you manage this testing, the question of vaccine, and as these scientific developments occur, you've got rapid testing to know immunity, so that would be helpful for patients to know that they're already immune or that care providers are immune. But then do you quarantine? And once someone has been identified as positive, does that mean that, okay, so now she's positive, that means I was with her, so does that mean the rest of the staff that was in the office also gets quarantined? And when did it occur is unknown. And then it can be very helpful, on the other hand, to know who not to take care of, which certain patients we would not want to take care of. And of course, there's the idea of, the questions in the past of history, I was in Wuhan or I wasn't, and asymptomatic shutters, all that just makes it very difficult.
Yeah.
But yeah, I was going to say too, with South Korea and Taiwan, they used these ideas of, testing, readily available tests that really helped mitigate and I think control the spread much differently than, other locations, but it's still very gray area. And, is it a cold or is it COVID? And self-isolation, false negatives, all of that creates a lot of difficult management and decision-making. Yeah.
The last time when I was looking at the studies, there is a study that looked at all the isolates that have been sequenced from COVID pandemic across the world. They have found more than 229 mutation.
Wow.
229
Holy
mutation.
cow.
The scale of mutation. They said that according to they made a tree. Imagine with only 3 months of testing, they could actually come up with a phylogenetic tree due to such a high diversity. They said that the mutation rate is approximately 1.5 per month in any little region that has the,
wow.
It will mutate, have an additional mutation 1.5 per month. So if you look at the species that are in Europe, they are very different from the one that are from Wuhan. and the one that are in the US are also slightly different. So um, the genetic makeup is pretty diverse. And
Yeah.
the implication is that if you wanted to design a vaccine, to what type of strain you're going to design the vaccine for. And
Wow.
earlier, you guys were talking about false negatives. One of the reasons of false negatives in antibody is that it was designed for species or for strains that are from Wuhan that are slightly different. And so when you try to build an antibody a detection system for that, it does not necessarily translate in high accuracy when you look at different population. So I think
How many mutations did you say that was? It was 200.
29
That's
today,
crazy.
till today. Yeah.
Holy cow.
So
Yeah.
that was your lecture, right, Nabil? Where
Yes, exactly.
You talked about all of that. I know. That was amazing to me. It's unfortunate that none of those mutations rendered the virus inactive, that it remains fully active in spite of the mutations.
Yes.
Wow.
Yes.
Changes the antigenicity, but other than that, it's all still very active. Yeah.
Exactly. Exactly. Very good. We wanted to ask some questions. Our guest, Dr. Jason Swain, is the laboratory director for CCRM. I want to get your feedback on the IVF aspects and COVID-19. So tell us a little bit, what challenges are you currently seeing in your daily practice in IVF when it comes to COVID-19?
Yeah, so thanks for having me. I want to preface this by saying that I'm by no means a pandemic expert. I think we're all learning as we go, and we're all trying our best. And so from a lab perspective, stopping care was a difficult thing to have to manage with all of our labs. So that meant layoffs, furloughs, reduced schedules. So just from a personnel standpoint, that's a very difficult thing to do. And now we're not really doing volume. We're doing a few cases here and there, some diagnostics. We are getting ready to try to ramp back up. So we now have to try to bring those lab staff back. And we want to do so in a controlled fashion to not overstaff. There's a financial aspect that we all have to be concerned about, but bring back enough staff to handle this influx of patients. And so there's going to be a scheduling component that's very important to make sure that we don't try to cram this backlog of patients through in a short amount of time, because ultimately in our staffing, we're essentially going to be half staffed if we're working in teams to try to minimize exposure and have social distancing. So even if we had, say, 4 embryologists and we work in 2 teams of 2, our lab capacity is essentially cut in half, because we ideally would not have all 4 people in on the same day in the lab. So there's going to be some difficulties there in figuring out how do we ramp back up safely, but also get that volume that we're used to doing and to keep our patients happy.
Yeah, definitely. The operation is a challenge, as you have to manage the number of personnel that are handling the operation, of course. But in terms of the potential risk of COVID-19, what adjustment would you make in the lab to try to minimize, because you're dealing with a virus that you're not necessarily going to see on a petri dish. It's not going to, so it's hard to detect. How would you manage that, not knowing what you have on hand?
So as was mentioned, universal precautions are even more important now. They were obviously extremely important in the past. We've dealt with patients with infectious diseases in the past. This one's a bit unique. So we've talked about kind of social distancing, working in teams to try to minimize that staff to staff. The physicians obviously have talked about how we try to minimize patients in the facility. That includes men dropping off samples and people in waiting rooms. Within the lab itself, I don't know how big of a concern this is over, say, our standard HIV or hepatitis patients. Yes, this is a different virus. It can be aerosolized. But in our laboratories, we work in isolettes. And so if you hand us a tube of fluid that's capped, we're protected in an isolette. We do have PPE on, face masks and gloves. So we're not splashing blood on ourselves. For labs that may work in hoods, those are usually class 2 hoods, which are meant to protect the user. You could turn that airflow off if you were concerned about somehow causing aerosolization. There was a recent, so I don't know that there's too much concern from the follicular fluid that could be contaminated with the blood. In terms of semen, there was a recent manuscript that I think is now circulating on Twitter. I'm not sure it was submitted by Jim Hotling and others on 30-some Chinese men, approximately 30 days after infection, and they identified no virus in semen. But again, we process semen in a hood. We use PPE. So I don't know if there's any concern of, contamination to staff there. In terms of, concerns to the gametes and embryos, I don't know that there's ACE2 receptors on the oocyte or the embryo, although right before this call, one of our physicians said that she had heard there were receptors on the blastocyst. I'm not sure of that. So I don't know that there's going to be any impact on the development of our cells. And then in the laboratory, again, with cryopreservation and tanks, not knowing if somebody is positive or negative, it's not really possible to quarantine people. We've got people that we know have viruses, CMV, for example. We have those in our tanks. So COVID is a virus. It's something to be concerned about. But through that process of dilution and storage in our tanks, I don't know that there's really anything we can do to really protect our patients in terms of how we store these. You could have new tanks. I've heard labs talk about that. That's going to protect your existing historical patients. But the issue there is you're now mixing potentially positive and negative patients in the same tank. So you're not really protecting your current patients. It's impossible to know whether that's really a concern or not is debatable. And then when do you draw that line of when you start that quarantine process? Is it January 1st? Is it February 1st? And then when do we stop? So, our precautions are being very diligent in use of our PPE, trying to have as much social distancing and minimize patient contact, being very aware of not dropping dishes into trash cans and things where you could cause splatter or issues, just being very safe use of PPE. And then listening to our lab staff. If lab staff have got concerns, we try to address those. You can reassign people as we try to open.
So when it comes to segregating, specimen that are cryopreserved, would you dedicate space just for post COVID-19 in case, or what? Or you're just going to continue basically the same with same precautions?
Yeah, so we're not planning on having separate quarantine tanks. Now, in any busy lab, you do buy tanks. So at some point when we buy a new tank, we can start putting patients in there, but there's really no quarantine possible because you don't know who's positive and negative. And the reality is you're co-mingling these patients. And so that may be peace of mind for prior patients. And so there's nothing wrong with doing that approach, but I think from a safety perspective, I don't know that it's actually really accomplishing anything.
Okay. What do we know so far from these, from other cases, let's say in China, because China has started early on, a few months ago with the pandemic. Are there any studies that can give us some ideas of how to proceed as far as risk and clinical impact of the patient that were born with the infection, the impacts on the baby or during the pregnancy, or all these aspects from culturing all the way to delivery? Do we have any case studies?
I'm not aware of anything from an infection from IVF in terms of transmitting an embryo back to a patient and carrying on that infection. And that's with any virus. There's a lot of hypothetical, and Kim Pomeroy and others wrote a very good paper a few years ago that's published that talks about, finding viruses in tanks and the dilution factor and how big of an issue really is this. So in terms of specifically to this particular virus, I refer people back to that publication has been mentioned in several webinars in terms of, what is this true risk to the patient, and the physicians would have a better idea in terms of, impact on offspring. I don't know that there's a lot known about that, but in terms of, possibly infecting a blastocyst and somehow transferring that virus to the female patient, having it impact the offspring, I'm not aware of any publications. Maybe Dr. Beltsos or Paulson have a different view.
Dr. Beltsos, what would you do, or what would you say about the IVF the aspect, the IVF lab aspects, how would you manage the IVF lab given the situation where we are?
Well, I think Jason did a very eloquent job of going over some of the things that we know, we don't know, and this idea of expression of the SARS-CoV-2 receptor on the blastocyst was seen in this paper by Koleko. And it's, then it adds an element of fear if we didn't already have it. But I think as far as the lab itself, and, one of the things is trying to keep our precious embryologists safe. They are very difficult to replace. I might be able to answer the phone like my front desk, but probably not as good as they can and manage their job, but I certainly couldn't do Jason's. So how do we keep them and, a little bit out of the way? There are times we have our embryologists talking to patients. I think, like you said, managing the staff, exposure to other humans and keeping them at distance. I think the idea of quarantining, if you will, is a very difficult one when we don't, when do you start, when do you stop, and is everyone going to be in their own tank? That would be impossible. But the aerosolization idea of follicular fluid from the eggs, from the sperm, are also ones that seem that this thing does not transmit through cells, and it seems to be more respiratory in nature, but I think there's a lot we don't know. To ask, what do we do in the lab that, I would be, let's say, interacting with, I think doing the very important precautions that we've discussed. I think as far as, embryos go, and we talked a little bit about what do we do with third party, the 28 days of asking a donor if they've been around any exposure. And I think when we talk about the testing, that's going to become very important in third party as well. And when they do show positive, do you wait 28 days or do you quarantine people that have, who are, come back positive and you've got embryos in the lab? Do you keep them separate? I don't know what to say to that.
Very good.
Well, and it begs the question of a third party situation where, let's say you collect the eggs from an egg donor and you quarantine them, and fine if the donor doesn't have any symptoms, but what if the donor does actually develop symptoms? Now you've got embryos in cryo storage. Now what do? Do you throw those out? Do we have any reason to think that that the virus can be transmitted through an embryo? I mean, it would be a very difficult situation. I was not very happy to hear that the SARS-CoV-2 virus attacks the kidneys and patients go into renal failure. So I thought it was all just respiratory, and that's all. That made sense to me, and I could sort of package that away. The fact that people are now showing up with renal failure means that it's circulating, which means that it's attacking other tissues. If it's in the transitional epithelium or I don't know where it is in the kidney, if it's the loop of Henle or where it is, does that mean that it can get into other tissues as well? And then we really could get it in reproductive tissue. So yeah, it's tough. Yeah.
And on the IVF laboratory aspect, what would you like to add to what Jason has already said before? Would you make any adjustment in the lab and IVF lab beyond what you guys are doing right now?
Well, I think what he said was great. You cut the staff in half so that it makes it a little easier to stay 6 feet apart. That effectively cuts your volume in half. And that's analogous to what's happening in the clinic. So that's kind of the person-to-person transmission. The rest of it, I don't know. It's all speculation about follicular fluid, but how dilute would that have to be to have it come out of a micro droplet through the oil and somehow get into the person? So I'm not sure how concerned I am about getting the laboratory people infected from the material in the laboratory. To me, it's more management of the reproductive tissues, how the lab people, because the lab is often a pretty crowded place, how they can manage physical distancing and still continue to really be able to provide the care that we want to provide.
Very good, very good. Jason, what advice would you give to other lab directors, embryologists that are currently about to resume work or they are working?
Yeah, I mean, I think doing exactly this. There have been a number of educational webinars where we talk about the practicality, because as I said, we're all learning as we go together. And so communication with your physicians, communication with your staff. You know, as some of us know, hey, we come up with great ideas, and you know, we talk to our various physicians, in our case, 11 locations, or our lab staff, and they have a completely different perspective for one reason or another. So listen to others. Everyone's got some great ideas. You know, and realize that we're in this as a team. We're trying to do what's best for our patients, but also what's best for ourselves and our staff. And, you know, listening to other people, educating ourselves, and having an open mind, and making sure that everyone feels at ease. What you don't want is someone to feel like they're being forced to come into work. You know, that creates a multitude of issues. We all want to be there. We all want to help our patients. And so we want to create an environment where the staff feel appreciated and safe. And that they're heard if they do have concerns.
Fantastic. Dr. Beltsos, would you like to add something before we go into the questions asking the audience? Would you like to add something?
Well, I think as we begin to open doors and go forward, I think we should be a little less aggressive with our stimulation protocols, just to be extra careful about ovarian hyperstimulation and its risks. A more liberal use if one's not doing, you know, Lupron trigger, cabergoline, things that can mitigate, God forbid, that severe OHSS, that if someone had that on top of COVID could be, you know, very concerning, and doing more freeze-all, which I think a lot of us are doing. And, you know, since there is already a movement towards that, less monitoring, I think, can be very important. And then just reminding the patients that as they go through this, to be extra cautious if we weren't already, about risk of torsion and, you know, exercise movement, so that, you know, those emergency, which are rare, but emergency surgeries would be, you know, even less likely, since we don't want to have patients going into the, you know, into the hospital. So I think those are important and creative ways to manage our patients, but also our staff. And I think, Jason, you brought up a really important point, and that is that we do want to always keep our staff and our frontline soldiers, the people that are really in front of our patients, as safe as possible too.
Absolutely. Dr. Paulson?
Well, I mean, to me, what's perhaps most disquieting is every time I think I've got the situation packaged up in my head, I don't. Some new twist enters the fray. It's like the analogy of the renal failure. Who knew there was going to be a renal failure? Who asked for that? And the fact that as well-meaning as we are, and as many precautions as we take, we might not be taking the correct ones right from the start. I think that's a realization, and that took me kind of a while to get adjusted to. So I feel like we have to provide the care to our patients, and we have to get started. And so we have to explain that we don't know what we don't know, and but here's what we know as of today. And please understand that in a week this could be different. And please understand that 2 weeks from now, when we have your embryos frozen and you're ready to come back for the frozen embryo transfer, there could be a new twist. And we'll think of something else we could have done that we didn't think of because we didn't know that it was important. So I'm getting my head adjusted to that. I don't know how well I'm going to communicate that to the patients to try to get them to understand. A lot of them really just want to have it done. They want to move ahead, and they're not, you know, processing, I think, with adequate level of caution, the things that could potentially go wrong, like Andrew was talking about.
Yeah. So if you have a chance to talk to your patient right now, what would you tell them? What message would you give them?
Yeah, I mean, I think for those who are not really in an urgent hurry, I think, you know, every 2 weeks, I feel like the world is very different every 2 weeks, maybe even every week. So if you can hang on for another couple of weeks, I think that would be good. If you're 32 and you can wait another month for your IVF cycle, maybe that would be a good idea. If you really feel like you got to go, then here's what we know and what we don't know, and I can just do my best to try to give you my informed consent. But the informed consent really is, we don't know very much, and please understand that there are risks that you are taking on that we don't know that you were taking on at the time that we allowed you to go forward. I think that's what the consent is. That's the one that I'm formulating in my head that I'm going to try to put on a piece of paper. I think it's going to have words to that effect.
Dr. Beltsos, what would you say to your patients?
I think that as we are talking to people, we've gone over the risks of vertical transmission, which appears to be very small. There are risks of fever in the first trimester, third trimester. So as we move to getting people pregnant, embryo transfers, IUIs, I think having these important conversations with our patients about being pregnant, as well as the risk of being infected. I know some of the questions are, what if someone is infected? Well, we expect that 40 to 80% of the population will be or has been infected with COVID. It's extremely contagious and it's very prevalent. We don't have very many people who actually got tested, right? So that number that we see are the very sick people who qualified for testing. But the reality is we're probably around it all the time, and the universal precautions assume everyone has been. Specifically though, if someone was tested, I think that question comes up is just, knowing following the recommendations of the CDC are going to be important as patients come into our office. And the other part is have a conversation with your doctor so that you can figure out when is the right time for you to proceed.
Fantastic. Well, we have some questions. I think Miriam is going to take the questions from the audience, and then we'll ask the panel. Miriam, are you there?
Yeah, I'm here. So I'll start off asking a few of the questions that we've received from the audience. But first, can we release the poll questions? Dr. Ash, you would have to do that.
Oh, okay, sure. And how I do that? Poll, okay.
And I'll start off on the questions. So the first question from Jay asks, the poll was just released. It asks, when do you plan to fully open? Will you do FETs to start and then throttle up to full force? And will you test patients?
Well, I think we kind of addressed that a little bit. I don't know about quote unquote full force. I have to tell you that even in looking ahead, let's say to July, August, when hopefully we'll be smarter, we'll know more things. I'm not really anticipating having 100% of our volume. I still think that a lot of what we do is semi-elective, particularly, let's say, oocyte cryopreservation. And I suspect that the pent-up demand that I keep thinking we're going to have is probably not going to be there. So I'm anticipating that we'll get maybe to 70% of our original volume. That's what I'm thinking. But when we're going full force, some of the clinics, of course, have not closed, and they have stayed open the entire time, doing fresh transfers, frozen transfers, everything. And so I would anticipate doing all of those. Will we test patients? I probably, because by then I think the testing will be quicker and we'll have a better sense as to the false positive. So then we can really give you a consent. We can say, your antibody test is positive, your risk of developing an infection by our best information is low, or you have a negative PCR, and in our experience and with the prevalence in our area, that means that your risk of acquiring the disease is 1% or 2%, whatever it is. At least you can have a number that you can give to someone as far as the consent is concerned.
Mm-hmm.
That's what I'm thinking. What about you, Angie? What do you think?
I would imagine the part about testing is going to be involved, but it will be necessary. And I think that'll be implemented into our patient care. I think the other part about how to begin, we are expecting that we're going to be now in this next upcoming month offering to proceed with caution and allowing people to do procedures. As we begin to do that, our usual way that we started patients was in series. So we had a series coming up, and I think what will happen as we navigate this is some of the more urgent cases, we will have some of these conversations directly with the patient and finding out if we are able to proceed with them. And then the transfer part is another question, and we will start to have those conversations as well. And then those that want to proceed without the discussion will go into conversations and a waiver about that being a responsibility of the couple, that they do want to proceed and not follow ASRM recommendations.
Next question was from Christian, asking, as we can start doing IVF cycles for all patients that are waiting, if you have to do a priority list, what are those patients, or what patients would you prioritize?
I think the patients that we are looking at are, as even what we were saying before, the patients with diminished ovarian reserve. We've had some patients who've had medical therapies in preparation for their IVF and or embryo transfers. We've had urgent matters. We live in some mandated states, and so some insurances, I know we have a couple, they were laid off and their insurance runs out in this next month and they will not be able to afford care. So that would be a financial urgency. And I think you're gonna have to have conversations one-on-one with patients, and those that have a little liberty of time, that we encourage people to hold tight for another month or so. But those are these conversations that we're having right now and talking about this are gonna happen, I believe, for a long time to come, because we're not, yeah.
Well, I was just going to say, so I think the patients themselves will tell you who's the priority. It's the patient that comes to you and says, yeah, I need to be done now. I can't wait. I can't wait. This is a priority in my life, and I'm experiencing distress and I need to move ahead. We actually had that conversation here because what do you do if you're trying to limit your volume and now you think you're going to have this very high rush of patients? And my feeling is that we probably will not have that big a rush of patients. I think that there is going to be a fair number of patients who are going to say, I would just as rather wait until this blows over. This is not a good time. My 401k. So we're in California, which is supposedly a mandated state, but of course, most of our patients do not have medical insurance for this. So it's cash out of pocket. And when the market is down, we notice a significant decrease in our volume. So it'll be economic, it'll be social, and it'll be, I think, concern about the coronavirus that I think will limit our volume by itself. And the patients that want to be done because they really are feeling the pain, I think are going to be the ones that will come in and will provide service for them.
Thank you for your feedback. So next question is actually for Swain. Christian asks that many people say that we can use ethanol and chlorine to clean up the lab. What's your opinion on it? And is hydrogen peroxide better?
So you can use those first two disinfectants. The concern obviously being VOCs. And so if you're somebody who believes in the adverse effects of VOCs, you probably not want to use those, especially in an enclosed space like an isolette. So peroxide can be used. There are also embryo safe products, Fertility Safe wipes, oocyte wipe, these kind of ammonium-based quaternary disinfectant products that you can use that are not embryotoxic. So I know labs still use a 70% ethanol solution. Some people use dilute bleach. We use peroxide in our labs or other approved non-VOC disinfectants.
Marina asks if you can talk about closed vitrification systems versus open in light of COVID-19 concerns.
Sure. So if you're truly concerned about somehow having viral transmission, despite the extreme dilution factor that occurs when you're putting these things into tanks, you could look at a closed vitrification system. I guess I would say that if that was a concern, it should have been a concern prior to COVID, because there's other viruses that we deal with. Closed systems can work just fine. A lot of the systems are open. So it really, I guess, comes down to what you and your lab feels is appropriate. And I guess I would say that we all want to do what's best. We all do want to re-examine some of our protocols, but at the same time, let's also stop and pause for a second and not overreact. To me, completely changing our vitrification system is a significant change, one that I would really want to look into and wouldn't base strictly on this COVID-19 pandemic that we're dealing with right now.
The next question is from David, asking all panelists, do you plan to test all patients for COVID-19 when your clinics ramp back up?
Yes.
I think at the moment, I'm not sure how we'll navigate all of that conversation, but I imagine on one hand, it would be very helpful information. And then on the other hand, as we talked about, pretty much everyone has been exposed, not everyone, but you know, again, the majority of people will have been exposed and have immunity. So how will we navigate those conversations and the information and what decisions would be made with it remains unclear to me.
I mean, the reason that the answer is nuanced is because the testing is a moving target.
Yeah.
So if the test is expensive, uncomfortable, imprecise, and takes a week to come back, that's very different if you have a specific, accurate, inexpensive test that has a 15-minute turnaround. That's a completely different situation. In the latter case, you test everyone every time they come into the office. In the former case, you have to question as to how worthwhile that is.
Yeah.
Herman asks, how about testing the staff? Do you plan on doing that?
Well, I think for everyone's peace of mind, if we can really have a good serological test, if you knew that you were IgG positive, that would be very helpful, right? That means you've been exposed, you're unlikely. So we don't know yet whether this is going to be the case with COVID, but in the vast majority of viruses, if you have an antibody, that means that you've been exposed, your immune system has fought it off, and you now have at least some degree of immunity going forward. So I think that would be very encouraging. That's primarily the kind of testing that I see. Or someone says, I had to run to the ER yesterday, and I'm very nervous about it. And then I suppose you could test that patient, but you know, how long does that take to turn positive? How reassuring is that test, and so on? But I think yes, testing the healthcare providers is a smart thing to do because they have a great ability to transmit the virus to someone else. They also are nervous. They're being exposed on a regular basis. So I think that's a very good group to test first.
Yeah, it'll be interesting as that test becomes more common, and even if you have your in-house assays and machines, then you know they're also beginning to pivot and be able to run it on your own in-house machine versus some of our great colleagues that are offering it as well. And I think that the ability to do it, who's going to pay for it, is it covered by insurance, how much does it cost, and what are you going to do with all this information is going to be something that's going to be probably another Progenesis Academy webinar as that comes out, and I'll be anxiously listening and waiting for the answers.
We have a question from Frederick asking what percentage of peroxide do you recommend for disinfection?
So we use just a basic 3% peroxide. So anything more concentrated, you're probably running the risk of doing some damage to yourself or to your equipment.
And then would vapor phase storage be preferable over storage of gametes or embryos in liquid phase?
So that's generally been the approach taken if you're worried about infection or cross-contamination between samples. Vapor storage, obviously, we all know that there are some increased risks with that approach. But if you have access to vapor tanks as your bulk storage and can handle patients, sure. And again, that would be independent of just COVID. That would be hepatitis, HIV, any sample where you're worried about some sort of cross-contamination. We know that there are some good vapor tanks out there, but there are additional considerations to make sure that we're aware of if you are using that approach.
And I think with that, it concludes the questions that we've received. I just wanted to thank all the panelists for answering all the questions. And we would also be releasing the polls for the questions that were asked from all the attendees. Dr. Rosh, do you mind closing the poll and releasing it? So the first question asked was, is your clinic currently taking IVF patients? 41% of the attendees said yes, and then 59% responded. The second question was, does the recent statement from New York's governor affect your practice in any way? 17% responded yes, 46% responded no, and 37% responded not sure. The third question was, going forward, do you anticipate any changes in the way you manage IVF patients? So that be PPE policy, screening patients or staff. 85% responded yes, 7% responded no, and 7% responded no, not sure. And the last question was, how soon do you expect to reopen your clinic? 37% responded within the next 2 weeks. 50% responded in a month, and 15% responded 2 or more months.
Very interesting.
Dr. Rush, you're muted.
Perfect. Any feedback from the panel on what we see as far as poll results?
I think it's interesting. Yes. So 37% plan on opening in the next 2 weeks. I presume that would be the 59% of the people that are not currently taking IVF patients. And I think we're getting that sentiment around the country. I'm not sure that the ASRM guidelines are really in line with that. But the problem with the ASRM guidelines, of course, is that they're trying to give out guidelines for the entire country, for the entire cohort of IVF clinics. And as we said at the beginning, there's such a difference between whether you practice in Los Angeles or Chicago or Wisconsin or New York. So I think it's going to be, and it may very well be that the answers to the poll are also regional, and that we have different answers from different locations.
Dr. Beltsos, any feedback on the polls?
Well, I think for me, the part about 37% and 50% tells you within the month, we expect a lot of clinics to be providing care. And that is the vibe I took away from the Stephen Palter segment last night, with the ASRM task force talking to 2,200 care providers or scientists. And that is navigating some of these conversations. I do think that many of our patients are emotional, but I think many of our patients are also looking for guidance and wanting to, navigate their journey in the context of being safe. So, but I do think that we're going to see now a shift in the number of people doing IVF in the next month or so.
Sure. Dr. Swain, any feedback on the poll?
No, I agree. I think we're seeing people kind of come to terms with, you know, our new normal, and we'll ease back into it, and we'll have to be vigilant. You know, if there are recurrences due to seasonality or hot spots, you know, there's another reason to proceed with caution. And I think everyone, regardless of whether you're open now or not open or going to open in a month or 2 weeks, I think everyone is trying to make sure that we do this safely. For everybody, for the patients, our staff, as well as ourselves.
Very good. Well, with this, we came to the end of the webinar series for the Progenesis Academy. I would like to thank our wonderful panel, Dr. Beltsos, Dr. Paulson, and Dr. Swain for the participation and feedback, and you know, the amount of information we have received. And I'm sure that other clinics and other embryologists and IVF, you know, staff will see a little bit of direction that we were missing. I would like to thank all of you. I will see you next week with another webinar series. Keep in touch and check your email. Thank you so much. Thank you.
Thanks, everybody.
Thank you.
Thank you. It was great.
Everyone.